Hello everybody, and welcome to the Tuesday edition of Video Clips. And I have just a few announcements. Tomorrow, or tonight I guess it is, we're going to start the Food Over Medicine coaching program training. And I'm very excited about this. I finally have enough time to spend on this, which I wanted to do for a long time, which is to expand the teaching of the concepts based on my book, Food Over Medicine, to teach people how to do more with the information in that book, and then to start Food Over Medicine chapters around the country, which would give us a way to help you to build a business around the concepts of food over medicine, and partner with us because we have enormous resources here in terms of people and content and support and education and all that sort of thing. So if you're interested in joining us, and if you listen to this after we've already started, still send me an email because it might be something that you want to do. We always record the classes. You can catch up, okay? Keep those emails about careers coming. I'm having great conversations with you guys, and some of you are jumping on board to become health educators and food over medicine instructors and coaches and all that sort of thing. We have a lot of options available here, ranging from something that's fairly simple to something that clones me, for example. So pampopper@msn.com is the address you want to email to. And then I'm really excited. Some of you know that one of the subjects that I have done a lot of research on is inflammatory bowel disease, Crohn's and colitis. And I have been gathering enormous amounts of data for the last 18, 19 years, and a tiny, tiny fraction of what I have is used in our courses for gastrointestinal diseases and diet and lifestyle intervention course, and our booklets that we give to people who come in here for information about IBD. So I'm finally organizing this massive amount of content into a course, and I'm going to teach it starting in July. And so if you are interested in taking that course, send me an email at pampopper@msn.com. I think July 10th or something like that is the date that the course actually starts. But I'm excited about this because there's so much more to share, and I finally have the time to organize it. And by the way, one of the reasons is I got my book finished last weekend, which is The Yo-Yo Effect, based on the movie called The Yo-Yo Effect, that's actually going to have a different name when it comes out in July. Long story around that, but you will have another book of mine to read soon and a movie to see as well. So I've got time to spend on IBD programs and food over medicine coaching programs and helping you be more successful in business and all those great things. pampopper@msn.com, and we'll set up a time to talk. All right, I have two things I want to talk about today. The first thing is just aggravating, and then the second thing is some of you have heard about the changes in guidelines about which women qualify for chemotherapy when they have early stage breast cancer. So I did a little research on this and combined it with some other research I already had, and I'll give you some commentary. But first, let's start with the aggravating thing. Well, I guess it's all aggravating in my world, but I'll let you decide. A research group has identified a risk factor for obesity in women that could lead to a diagnostic test that would identify people at risk of becoming obese, and then we could have earlier intervention. So researchers at the Karolinska Institute collected fat biopsies from 89 women who were healthy and not obese at the beginning of this, and then they followed up with them 13 years later. Women who gained weight showed impaired lipolysis, a process by which triglycerides are broken down into fatty acids. The women who gained weight also had lower expression of genes involved in regulating fat breakdown as compared to women who maintained stable weight. The researchers reported that insufficient lipolysis seems to facilitate growth in fat mass. The researchers then developed a method for estimating the rate of hormone-stimulated lipolysis based on factors like waist circumference, fasting LDL cholesterol, fasting plasma adrenaline, body weight, fasting plasma insulin, and fasting triglycerides. They tested this method on a group of 226 women and were able to estimate the women's hormone-stimulated lipolysis levels and to predict whether or not they would gain weight in the future. One of the authors, Mikhail Ryden, said, quote, "Our proposed algorithm could be useful in identifying subjects with a high risk of becoming overweight or obese. This information could be used by clinicians to determine who would benefit the most from intensified lifestyle interventions such as physical activity." I want you to think about this for a minute. The study and the buzz that it generated are symptoms of the ways in which medicine has gone totally off the rails, in my opinion. Let's start with the risk factors for reduction in lipolysis, like waist circumference, plasma cholesterol, insulin, triglycerides. No doubt people who have these types of poor markers are at higher risk of becoming obese. Why is this? because the diet and lifestyle habits that lead to higher LDL cholesterol and triglycerides, for example, or an increase in waist circumference are the same habits that lead to overweight and obesity. Duh, we know this. Why are we wasting precious research dollars looking at this issue again? We also know that the right diet and lifestyle habits have a positive effect on these markers and a positive effect on weight status as well. But researcher Ryden states that the information will tell us who will benefit from intense physical activity. We're now looking for the subset of the population that benefits from physical activity. I mean, this is insanity. Everybody benefits from physical activity in an optimal plant-based diet. Well, a significant amount of research money is torched every year, as that's my term for it, looking for the cause of obesity, as if this is some kind of medical mystery that we just haven't solved yet. Here's a hint. Obesity is not caused by a particular strain of bacteria in the gut, a fat gene, a missing neurotransmitter, or faulty wiring in the brain. Research into these areas misleads obese people into thinking that the solution to their problem is outside their control, and it just provides such a great opportunity for product and program developers to take advantage of the chronically obese with drugs, herbs, hormone treatments, schemes, and prepackaged meals. Preventing or reversing obesity requires work, and the work includes changing one's thinking patterns, rearranging schedules in order to make more time for health-promoting activities, and learning skills like persistence and resilience and discipline. I think the sooner we acknowledge this, the sooner a lot of suffering people can start to feel better, and the incidence of overweight and obesity will be reduced some. And so my aggravation with this is the redundant nature of so much of what we do. I mean, I can think of a million research projects, I'm not kidding, that actually would have some benefit where we would find out something new. And one thing that crossed my mind when I was reading this is a woman who just wrote a book on children, on families who have children that have unusual diseases, where very few children are affected, and how little research dollars there are for something like that. Now, can you imagine having a child that has a disease for which there's no treatment, and you have to go raise the money yourself to get more research to be done on this particular disease? In the meantime, we're trying to figure out who qualifies for physical activity. I mean, give me a break. All right, well, let's talk about the new guidelines, or what will probably be new guidelines regarding chemotherapy. According to a new study, about 70% of women with early-stage breast cancer who are candidates for chemotherapy based on today's guidelines do not benefit from it. So just think about all the over-treatment that this has involved over all these years. Researchers found that women who don't qualify now for follow-up chemotherapy include those who have early-stage tumors between 1 and 5 centimeters, women who have no cancer in the lymph nodes, who have estrogen receptor positive cancer, test negative rather for HER2 protein, and have a score of 11 to 25 on a test that gauges the activity of genes involved in cancer recurrence. These are the women who, based on this new study, would not qualify for chemotherapy going forward from now. Now, the test that's used, I did a little research on this, is the Oncotype DX breast cancer assay. It's been available since 2004. It costs about $3,000, and generally speaking, most insurance plans will pay for it. The test provides a score between 0 and 100, and previous research has shown that a score under 10 disqualifies women for chemotherapy. A score over 25 qualifies women for chemotherapy, and the problem is that in-between group between 11 and 25 that has been considered intermediate, and nobody really knows what to do. There's no definitive protocol recommended for these women. However, most of the women in this category have historically been receiving chemotherapy with the idea that it's always better to overtreat than undertreat in the cancer business. I don't necessarily agree with that, but that's the philosophy that seems to govern a lot of cancer treatment. Lead researcher Dr. Joseph Sperano reports that based on this new information, many women were overtreated. He estimates that for every 100 women treated, 4 recurrences were prevented, so that means that 96% that's left were most likely overtreated and were harmed as a result of treatment. Now, just a little bit of information about the study. It included 10,253 women between the ages of 18 and 75, 70% of whom had that intermediate score that I was talking about earlier. All of the women had surgery and radiation, and then they were assigned randomly to either receive endocrine therapy alone, aromatase inhibitors or tamoxifen, or endocrine therapy plus chemotherapy. After 9 years of follow-up, 93.9% of patients taking only drugs were still alive. The patients who got both drugs and chemotherapy, 93.8% of those were alive. I mean, it doesn't even reach statistical significance. In the drug-only group, 83.3% had no invasive disease. 84.3% who took drugs and had chemotherapy were free of invasive disease. So what this really says is follow-up chemotherapy didn't do anything for 70% of the women, 96% of the women who had it, and 70% of women who come under those categories that I mentioned earlier. Now, this is a step in the right direction, and one big problem we're going to have is oncologists have got to be convinced to change their recommendations. Research shows that most doctors, not just oncologists, are very slow, and I think I read in one study, it varies depending on which one you read, that it can sometimes take as much as 20 to 30 years from the time that new information becomes available for practices to change. Now, if that doesn't scare you, I don't know what will. So the only group that will benefit from this information are informed consumers like you who are watching this, who will know that, God forbid, if you develop breast cancer early stage, it's highly likely you won't qualify for chemotherapy. Or friends of yours who are lucky enough to know you should this happen to them. Now, in order for women to make the best decisions, I think this should all go a lot further. Both follow-up radiation and the drugs that are used should be carefully considered too. Tamoxifen is a frequently prescribed drug as a follow-up for women with estrogen receptor-positive breast cancer to prevent recurrence. Women who take the drug have an average 2.8% reduction in the risk of recurrence. They have an increased risk of dying of breast cancer if they get it, and an increased risk of several other cancers, including endometrial cancer and non-melanoma skin cancer. Other estrogen blocking drugs have shown to be just about as equally useless. As for radiation, one study that looked at the difference between taking tamoxifen alone or tamoxifen with radiation showed that the reduction in the risk of local recurrence was between 3 and 7%, depending on the age of the patients, but there were no other benefits, no increase in survival or distant disease-free survival. And there are risks associated with radiation, which include the fact that if there is a recurrence, then lumpectomy is not an option and the breast has to be removed through mastectomy. Radiation also increases the risk of heart disease with a dose-dependent effect. The more radiation you get, the higher the risk of heart disease. So there is a tendency, it is moving at such a snail's pace that you just can hardly believe it, it's painful to watch, toward a little bit less treatment in terms of cancer in general and breast cancer specifically. But these are all reasons to, if you are diagnosed with cancer or somebody you know who becomes diagnosed with cancer, that you just want to take a deep breath, take your time, look at lots of data, outcomes data, before you jump into treatment, because so much of what is done does not help. And in the case of cancer treatment, not only is it not helpful, but the drugs and the treatments are harsh and harmful, which is why you really, really, really want to make sure that what you're doing is going to benefit you in the end. So that's the update. I have lots of information on treatment for lots of cancers that shows that they should be entered into very cautiously. This should be a cautionary warning to people that look into it. Look before you leap. You probably heard that before. All right, that's all for today. As usual, pass this on to anybody who you think would enjoy watching it, and I'll be back to you on Thursday with more news.